I'd also like to thank the organizers for having me talk here. When I started talking about PK, Tim did a good job of introducing one concept that I really like, and he showed that he matched the dog exposure of PAC1 to mouse exposure because it was safe. And I think that type of PK-directed dosing is something that we've tried to do, especially in terms of drug combination therapy, where if we have the human data, and I didn't bring the slide, but I have a slide that shows humans, data from dogs driving what we do in humans, but data from humans also drives what happens in some veterinary utilization of drugs. And so often the human is actually the preclinical species in terms of going forward for some things, and which is a concept related to the kind of One Health, where all information in mice drives dosing in dogs, mice drives dosing in humans, but human may drive dosing in dogs. And when we go back and do combination studies, we use human PK to drive the dosing back in the mice. So it is a circle in terms of exposure. So what I'm going to talk about today is pharmacokinetics and pharmacodynamics. I don't like biomarkers either. I'd call it pharmacodynamics, whether it be good or bad, it's all a drug response. So what I'm going to talk about is talking about doing PK studies in companion animals and some of the benefits and things we learn. I'll talk about the variability in that data, and this gets to Doug's question earlier about population-based studies and how we can use that variability to do more functional dosing. How do we utilize PK data? And I'll give an example, again, of PK-directed dosing and how we might actually direct human trials with what we're doing with the dogs. Talk about dose-finding studies that we do in dogs and how they inform PK and toxicity and how that's translatable. And then I'll end by talking about tissue sampling on PK/PD measures and give an example with an autophagy modulator that's very interesting because it actually was published along with 5 human clinical trials in a row, and a lot of what we did in the dogs was very informative to some of the things that they learned in people at the exact same time. So when we do PK studies in dogs, it's important to note that we can do time course sampling in individual animals, which is something you really can't do in mice unless you're really, really good at getting really small amounts of blood. Generally, we use what we call the super mouse model. You use 3 mice per time point, 7 time points. You turn 21 mice into 1 curve. In dogs, we can do like we do in people and get a time course over time to get an idea of drug exposure. This is, I think, underappreciated, but drug dispensing is done in a manner consistent with human medicine. You have a pharmacy, the pharmacists make up the drug, it's done per meter squared, so the variability associated with conversion from weight to body surface area, that the slop in that equation is carried over in your study. So it's not like you're making up drug, in a syringe and dosing into a mouse. You actually have this drug dosing done in a hospital setting. Sample collection is done by a professional staff. My lab's the core lab for the CU Cancer Center. We work with their phase 1 center there. We can tell virtually no difference between sample processing when it comes from the human side, the phase 1 clinic at CU, or the veterinary clinic at CSU. You have the same people the people are drawing samples, they know how to process them, they know how to freeze them, they know how to label them. So you have this professional grouping using defined standard operating procedures. So it's not done in a laboratory setting, it's done in a hospital setting. They come to us, since we developed usually the analytic assay. How do we do this? How should we process it? And again, just like from the human side, we're working in coordination with the nurses and the staff down there in oncology service to get the samples processed in the right freezer, in the right box, labeled correctly. So all the same good and bad associated with those clinical studies, because that's effectively what they are. So here are some examples if you want to look at variability. And I'd actually never put these 2 curves together until I was prepping this talk. And I showed it to Doug, and he goes, holy schmolies. So when you look at human pharmacokinetics, so this is doxorubicin at 60 milligrams per meter squared in just some breast cancer patients given either a 12 to 20 minute infusion, some data I had laying around. This is what it looks like over time. Here's N of 20 in dogs from a study Kim Selting did about, I don't know, probably 10, 12 years ago now. We did all the PK. This is at 30 mgs per meter squared in the dog. And these are both what they would call the MTD. And it's surprising how similar these curves are in terms of overall exposure, arguing that drug exposure, plasma exposure of the drug is really what drives dosing, as you would expect. The interesting thing to us is if you look here at the area under the curve, the total exposure, and the coefficient of variation, you can see that the variability associated with exposure is pretty similar between the humans and the dogs. So the same factors that drive variability in people, genetics, environmental differences, size differences, which are much more extreme in the dog than they are in the human. All those other factors play a role to give you variability, which is more reflective of a population. Now, that gets to the question that Doug asked earlier, is can we start using this pharmacogenomic data to start driving dosing decisions to make PK more consistent? Because ideally, you'd want this coefficient of variation to be 0, right? I mean, you'd want everybody given a set dose to have the same exposure. My answer to that is we don't have the data. I mean, you need to do population PK studies with real large data sets. It may be pharmacogenomic based, it may be eye color, it may be toe length, you don't know. I mean, there's just lots of variabilities that factor into that, and that's really a data intense process if you don't have known drivers that cause that. And I'd love to start collecting that data, but as of yet, we don't have the PK and demographic data to really address those questions. Here's another interesting example of variability in pharmacokinetics. This is 2 drugs, sunitinib or Sutent, and tacrolimus. This is a human drug. This is a canine drug. Their similarities are very clear when you look and you lay them over. The only difference is this bond right here. In fact, Pladia was part of the Sutent project that went forward for animal applications after Sutent. If you look, and these are the MTDs established and the doses that went forward in people and in humans, if you look at here at the Cmax in humans given 50 mgs daily, it's about 27.7 nanograms per mil. Now the dose that went forward in the dog studies was 3.25 mgs per kg every other day. If I do a on-the-napkin conversion, this is about 100 mgs per meter squared, so about 3 times bigger than the human dose, as you can see reflected directly in the exposure. The Cmin is lower in the dog, as you would expect, because they're dosed every 48 instead of 24 hours. So it gets lower before it goes up again. The area under the curve, again, is reflected by about that 3-fold increase in dose. So at the AUC, again, the exposures in the dog and in the human are very similar for these drugs based on this kind of exposure kinetics. So the variabilities are also relatively similar. 59, 62, 51, 32. So again, you're seeing the variability that you would expect to see in a human population in the dogs. Why is that important? Well, because you do have subsets of patients that respond and don't respond, that have toxic events and don't have toxic events. Can you tie them to PK? If you know you can tie that to PK, you know you need to be much more selective and much more careful with your dosing rather than dosing, maybe on mg per meter squared, or mg per kg or fixed dose. You have to find something to make that more normalized to enhance your efficacy and decrease your toxicity. And the fact that the variability that we see in the dog is very similar to what we see in the human at least gives us that platform to start exploring that. What can you do with that data? Well, here's another example of some therapeutic drug monitoring and some microdosing, something that's been discussed in people, and there are trials that happen. And when you don't have good markers, you can do low-dose studies and then extrapolate up to a dose to hit your peak. This is a study we're doing currently in collaboration with Bernie Segay, looking at dasatinib in osteosarcoma patients. And what we're doing is we're giving a very low dose of dasatinib initially, measuring time course, and then we're just doing a linear extrapolation because what they're trying to do is they're trying to hit a peak level of 35 nanomolar, which they think will be efficacious. So you're asking a very specific question here. If we get levels of drug here, and in this case we're doing it discretely within each dog by actual measurements, do you get better efficacy and less toxicity, the 2 pharmacodynamic endpoints we're trying to optimize. This is an example. We actually just yesterday got the data back here. This is something I just made up based on this. We were a little bit short. I think it hit 29 instead of 35, but pretty close. So we're getting there, and the rest of the curve went down. So this is, again, something you can explore in canine patient populations that you really can't do in other models that reflects what you can and do in people with regards to therapeutic drug monitoring and tailoring doses based on exposure. Okay, when we talk about dose escalation studies, and we had some discussion earlier today about proper schedules, Here's a dog phase 1 trial. This was done by Dave Vail and a whole bunch of people. I don't even know who the senior author there is, but anyway, a bunch of people. Oh, this is from Gilead. So anyway, in this case, there's a lot of different schedules that are tried, and the important point here is they're not just looking at one biomarker of efficacy, they're also looking at toxicity because, as mentioned earlier, those two things coexist in cancer therapy. You have to get efficacy in the context of a drug that's probably going to cause toxicity. So in this case, they did dose escalation, PK, and tox. They looked at exposure parameters shown here, measured both in the plasma and the PBMCs for this relatively complicated prodrug. So you have buildup of the toxic intermediate in the PBMCs that you didn't see in the plasma. So you need these larger samples and multiple sampling to get at the markers, the PK markers of response. And they were able to look at a more optimal schedule defined in terms of efficacy and toxicity. So going forward now, you know something that is minimized one of your pharmacodynamic endpoints, which is toxicity, while either maintaining or enhancing your efficacy pharmacodynamic endpoint, which is the more important one. So again, these dog phase 1 trials that are both PK and tox based are just like what you'd see in people, and they inform both sides of the equation. All right? Like in people, I assume these are safety studies, but seeing efficacy is certainly important for a lot of drugs going forward today, regardless of the stage of the trial. Another, I think, underappreciated component of companion animal studies is the fact that when we treat laboratory animals, I've never seen anybody give a mouse a 10-minute infusion with a slow push. It's just something we generally don't do. In fact, because of a lot of the issues with the fact that you're using very small volumes and the solubility of some of these preclinical compounds is so bad, a lot of times we give them IP, we don't give them IV, because we can't even get them in solution or they're in something pretty nasty like DMSO. So generally, your exposures in mice are going to look something very much like this. And Tim's data showed exactly that, right? He gave an oral gavage. It was either in solution or you needed no dissolution. You got an earlier peak, and that came down later. In the dog, when it was formulated as a pill, you had to worry about dissolution and grinding, and it came up later, but you still got the same exposure. So the fact that drug delivery in dog trials very often is done by infusion, where you can now use longer time frames to deliver drug that allows you to use less soluble compounds, and allows you to use solvents and things that are much more life miscible rather than DMSO and some other things that we have to use to give bolus higher doses that we try to give the mice. So I think that this ability to do slow infusions, and I'm not talking 24-hour infusions, I'm talking 10 to 15-minute infusion, things you can do in these animals, again, is much more PK-like what you would see in a person, given doxorubicin 10 to 20 minutes like we do in the dog, versus the bolus dose that gives you higher peak levels, which can have more toxicity and have nothing to do with efficacy. And you can change that play of efficacy and toxicity based on these peak levels, just based on delivery method. They're both IV. One's given over 10 minutes, one's given over a matter of seconds. It makes a difference. Okay. All right. The other important component is when you get into these phase 1 studies is that this toxicity assessment is graded and standardized. When we were having the discussion about mice earlier today, we've done mouse studies, you really don't, 20% weight loss is pretty severe, and you really don't care how they feel very much. You can't ask them, when you pick them up, they're going to poop in your hand anyway. So you're kind of at a loss for trying to assess some of those things that when these dogs are in much closer contact with people and go home with people that know how they act and know what they do all the time, you get a much cleaner assessment of effect of things like weakness and things like lethargy and other things that are major components of phase 1 trials in terms of some of the assessed toxicities. So if we go back to sunitinib in humans and to tocitinib in dogs, and you look at the toxicities and the numbers, the similar toxicities were observed across the phase 1 trials for these drugs, and some that were more species dependent. Similar ones were weakness, vomiting, neutropenia. Some of the species dependent ones, diarrhea, hypertension, skin toxicity that showed up in humans, not dogs, or dogs and not humans. Now, a lot of toxicities in drug delivery, somebody asked about drug delivery earlier. One thing about the dog is they do have about 30% more blood flow to the GI than humans. That for drugs that are perfusion limited with delivery, that's going to lead to increased exposure. Most veterinary oncologists know that GI toxicity is a major issue with a lot of veterinary agents. Why? More drugs getting there. There's just increased blood flow, and that's why Labradors are also always hungry. So a lot of those things go hand in hand. Okay, now when it comes to tissue sampling, here's the example I alluded to with regards to autophagy inhibition. This was a study, a phase 1 study that Doug Tham ran. All of the endpoints and the drug analysis was done in my laboratory. And what we did here is we were looking at the autophagy inhibitor, hydroxychloroquine. This drug has gone into people. It's FDA approved for anti-malarial. They know it inhibits autophagy, so there's a lot of trials. Like I said, I'll show you a list of 6 that were just published, looking at modulating autophagy with chemotherapy in human cancer patients. And so we ran a trial kind of parallel in dogs with lymphoma. We measured plasma levels of hydroxychloroquine and its primary metabolite, diethyl hydroxychloroquine, and we measured in biopsies as well. And a very important component is that there was no correlation between plasma hydroxychloroquine and tumor hydroxychloroquine levels. Why is this important? Because this argues that measuring drug levels as a surrogate for why or why not you're getting a response is completely irrelevant. They didn't do that in the humans, and this really helped direct some of the data they may have where there was no correlation between what was in the plasma and what was in the tumor. When we measure drugs, where do we normally measure it? In the plasma. And you assume that that exposure is equivalent to what's in the tumor. In this case, it's not. And a big part of that is hydroxychloroquine and chloroquine accumulate in tumors based on pH. So the pH of the tumor is going to be a much larger driving force of capturing the drug in there than just exposure from blood flow going through the tumor. You saw this about 100-fold difference. It does accumulate in tumor, but there was no correlation of either. Thus, using plasma drug levels as a measure are not going to be very helpful. The other thing is that we looked at PBMCs from dogs treated with hydroxychloroquine as a pharmacodynamic marker of autophagy inhibition. Are we inhibiting autophagy? We did see an increase in LC3 positive cells and an increase in autophagic vessels here, which that's what hydroxychloroquine does. It blocks fusion of the autophagic vessel with the lysosome, so you block autogolysosome formation or something like that. We also saw no correlation between autophagy inhibition and PBMCs in the tumors. So that disconnect between plasma levels and tumor levels also carried over to the biomarkers where when we looked at autophagy inhibition in the tumors, it didn't correlate to what we were measuring in the PBMCs. And this is highly problematic because that again tells you that your biomarker is not driving the presumed effects you might see. And that was, again, relatively informative to a lot of these trials. Here's the trials that were published: autophagy and HDAC inhibitor, hydroxychloroquine and radiation therapy, mTOR inhibitor and autophagy. I mean, there's a whole boatload of drugs here, temozolomide. And our trial here, which was published right in line with these series of human clinical trials. Ravi Amaravati, who's one of the major PI in a lot of these trials at University of Penn, I had the fortune of meeting with him and talking with him about these autophagy, about this hydroxychloroquine trial. He got very excited and wanted this trial published with these human ones because the dog data is so informative with regards to the lack of correlations between plasma levels and response. And with that, I'll gladly take any questions. I guess we'll wait until the end.